morning and welcome everybody to this session of lecture series on anterior mediastinal mass. The patient with anterior mediastinal mass provides an anesthetic challenge. Anterior mediastinal masses can cause compression of the airways and gate vessels within the mediastinum, and the administration of general anesthesia can be associated with a host of intraoperative complications. Careful preoperative planning is essential to provide safe perioperative care. Introduction. Anatomy. The anterior mediastinum normally contains the thymus, lymph nodes, ascending aorta, pulmonary artery, phrenic nerves, thyroid, and fat. Causes of anterior mediastinal mass. Tumors. In children, most common is lymphoma. In adults, most common is thymoma. Others include the teratoma, germ cell tumor, goiter, parathyroid adenoma, lipoma, carcinoma, aortic aneurysm. Presenting symptoms: shortness of breath, cough, hemoptysis, hoarseness, Horner syndrome, superior vena cava syndrome. The superior vena cava syndrome is due to the obstruction of superior vena cava and presents with dyspnea, facial swelling, cough, orthopnea, and headache. Surgical interventions: biopsy via mediastinoscopy or video-assisted thoracoscopic surgery. Definitive resection via sternotomy or thoracotomy. Perioperative etiology: effects of the supine position, decreased transverse diameter of the thorax, cephalic displacement of diaphragm, central blood volume increases, causing vascular tumors to enlarge. The result is decreased thoracic airway cross-sectional area and increased external compression pressure on the airways. If the airways or gate vessels in the mediastinum are already compromised from the effects of the mass, the supine position may be problematic. Effect of general anesthesia: decreased transverse diameter of the thorax due to decreased intercostal muscle tone, decreased inspiratory and abdominal muscle tone, cephalic displacement of abdominal contents, decreases the thoracic volume by 500 to 1000 ml. Relaxation of bronchial smooth muscles worsens large airway compressibility. Decision making in airway management of patients with anterior mediastinal mass, safe airway, that is in asymptomatic adult, unsafe, severely symptomatic adult or child, uncertain, that is mild or moderate symptomatic child with tracheobronchial diameter more than 50% of the normal. And what happens to the minimum tracheobronchial diameter when it is more than 50% of the normal? Unsafe in the children with tracheobronchial diameter less than 50% of the normal, regardless of the symptom. Uncertain in a mild to or moderate symptomatic adult with tracheobronchial diameter less than 50% of normal adults, or child unable to give history. If the neuromuscular blockade is used, the loss of craniocaudal movement of the diaphragm decreases the transpleural gradient, worsening the airway compression. The normal transpleural pressure gradient dilates the airways during inspiration, minimizing the effect of extrinsic intrathoracic airway compression. Controlled ventilation preferentially ventilates the anterior lung segments, causing dorsal atelectasis, leading to VQ mismatch and shunt. Hemodynamic physiology. Patients are at risk for hemodynamic decompensation if the heart or major vessels are surrounded by tumor. Superior vena cava is most susceptible to external compression. Decreased venous drainage from the upper half of the body causes decreased right ventricular filling, causes decreased cardiac output. The pulmonary artery is more resistant to compression, but decreased pulmonary artery flow can lead to hypoxemia, acute right ventricular failure, cardiac arrest. Large tumors can directly compress the heart, leading to arrhythmias and low cardiac output. That is the tamponade physiology. And this brings to the end of this session of video lecture. We will continue with the rest of the materials next day. Thank you.